Hi, Dr. Dutch. Thanks for joining.
You're welcome.
I've made you a co-host so that you'll be able to mute and unmute your audio. If you could
Okay.
just check that for me. Okay, I hear
Okay.
you loud and
I'll take
clear.
it right now. Okay.
Thank you.
And now I'm unmuted, so that works.
Thank you, everyone, getting joined. We'll be making a couple of quick announcements with instructions and getting started in just a few minutes. If you're a member of the media, we ask that you rename yourself with your full name and your media outlet so that we can identify you. So to do that, hover over your own video feed and click the menu that appears in the upper left corner. And under that menu, there's an option to rename. You can also click on the participants button at the bottom of the program and then find your own name under that list, and you'll be able to rename yourself from there. If our panelists could do the same thing, Dr. Dutch, if you could update your name and include your university name at the end of that, that will help for people to identify who each of the experts are. Dr. Ostrosky, I've made you a co-host so that you'll be able to mute and unmute yourself. If you could just give me a quick audio test, that'd be great.
Sure. Can you hear me?
I can. Thank you. Thank you very much.
Perfect.
For media who are getting on the call, we're going to take questions from you during today's panel. So I'd ask that you please take note of the chat function on Zoom and chat your questions to me. And we'll offer, if you'd like to ask the question yourself. If you don't want to, I'll ask the question for you. Meanwhile, if all the media on the call could please make sure to rename yourself so that we can identify you by name and media outlet. In order to do that, hover over your own video if you're on a desktop, and there's a menu that'll pop up in the upper corner of your video feed, and you can click an option under that menu that says rename and add your We're supposed to have the participants not able to unmute themselves. I'm going to double check that setting to avoid any interruptions. I've enabled that again. So please excuse us if we do have any interruptions. It seems like that wasn't working here right away today. Dr. Ostrosky, if you wouldn't mind also updating your name on the Zoom program with your university institution name at the end. We'll be getting started in just a minute or so. I want to give ample time for all the people who've registered to get logged in. We'll be starting right off the bat with questions for our panelists, and we'll also invite for media who are on the call to give us your questions. If you chat your question to me, we'll offer that you could ask the question yourself, or if you don't want to do that, I can ask the question on your behalf. If you need to figure out how to change your name, there's a couple ways that you can do that. Hover over your own video feed, and there's an option in the upper corner in a menu that has the option to rename. You also can click on the participants menu, and next to your name under that system will be an option to rename there. It's a little bit more tricky on a mobile, but I believe that clicking on the participants menu on the mobile app can accomplish the same thing. We are recording today's session so that we can provide video and transcript to the media afterwards. So if you registered for today's event, you're automatically on the list to get that information. If you haven't registered, if you just joined from clicking the link to today's meeting, you can email us and we'll get you on the list to get that video and transcript. So just send us a quick email to info@newswise.com and we'll make sure you're added to the list to get the video and transcript. Yes, if you'd like to get the transcript and video, please email us at info@newswise.com and we'll add you to the list to get that video. Someone had chatted that question. Thank you. We'll go ahead and get started. Welcome to today's Newswise Live expert panel. Today, we're going to talk about a couple of big topics: asymptomatic and pre-symptomatic transmission, the possibility of reinfection, and also the transmission of the virus and whether or not it can be described as airborne. We have with us two panelists. We have first, I'll spotlight his video. We have Dr. Luis Ostrosky. He's professor of infectious diseases at the McGovern Medical School at UT Health in Houston. And we also have Dr. Rebecca Dutch. She's professor and chair of the Department of Molecular and Cellular Biochemistry at the University of Kentucky. Thank you very much for joining us, panelists. And I'd like to start off with a question for both of you about the anecdotal reports about the possibility of patients getting reinfected. Dr. Ostrosky, how can you explain that for us?
Thank you very much for the question. So we've heard through media mainly about patients that have been sick for a while, they improve and then they get worse again and they test positive. And it's really hard to tell from these media reports if this is just long-term shedding of the virus and sort of long-term symptoms, which we're learning that can happen. and this is what's happening, or if it's really people that are getting actually reinfected or relapsing with the disease. So I think it's too early to tell whether you can actually get reinfected or relapse. We have not seen this described in the medical literature. It's mainly through media that we're hearing about these cases.
Dr. Dutch, tell us a little bit more about how we can differentiate between these two questions that Dr. Ostrosky mentioned, people who may not fully clear the virus and still test positive versus the possibility of getting sick a second time. How could we tell the difference?
That's a great question. So we do know that some people, when they're infected, are maintaining positive RNA for a long time. They can go weeks to months. So one way to do that would be, so that's a good possibility for what might be looking like a reinfection. If that's true, one way to do that might be to look over time and see what two things are. What are the viral sequence in there? We have the ability to sequence these viruses. Are you getting something different? Is yours look exactly the same? The other thing is to look at the timing between these. So, and this will be much more readily available or much more doable as time goes on. If someone seems to have cleared the virus, has had multiple negative tests, and then comes back infected 9 months, 12 months later, that would be more suggestive of reinfection than someone who a few months later, without being 100% sure has cleared the infection, is respiking sequences. So I think it's something that we absolutely need to keep looking at. I completely agree with Dr. Ostrosky on this. It's something that we will learn more over time. But again, it's a little challenging to answer the question when we don't have actual written reports of this. We simply have a few people who are making anecdotal stories about seeing a potential reinfection, and we won't know for sure. We do know with some of the human cold coronaviruses that over time you can get reinfected. However, we also know that with the people infected with COVID, most of them mount at least some kind of antibody response. It does wane over time. And the newest report suggests that people are all mounting a pretty good T-cell response, which would suggest that they are developing protective immunity at least for a period of time.
So, Dr. Ostrosky, we just heard from Dr. Dutch that to know this situation well, we may need to follow patients for 9 months or a year. We're only 4 or 5 months into this here in the US. Therefore, what does that maybe tell us, even though it's quite early, about how the possibility of reinfection, what that sheds light on in terms of how a potential vaccine might work? Are we seeing early indications of a waning immune response, even for those who have effectively fought off the virus? And does that mean that we might need regular boosters once a vaccine is out there?
So as Dr. Dutch mentioned very clearly, we know we mount an antibody response. There's some reports starting to come out that this wanes over time, over a few months. And on the other hand, we have other reports that are mentioning that antibodies are not everything. It's T-cell dependent as well. So your immune system cells trained to respond to this virus. Again, early to tell what's gonna be the sort of the play out of the situation. But if it behaves like other respiratory viruses and it doesn't mutate too much, I assume that we'll be able to have a vaccine that works for a reasonable period of time.
And Dr. Ostrosky, if it does turn out possible that someone gets infected a second time, would they hypothetically be able to also transmit the virus again, or is that likelihood less?
So if that happened and we were able to document that, this subjects would more likely be transmissible again. So, but again, we have no evidence in the medical literature that that has occurred.
So there's certainly a lot that we just don't quite know. I want to ask Dr. Dutch, with all of these question marks, what recommendations should people be following to take precautions if they've had the disease, to avoid the risk of reinfection for themselves or not to pass it to others?
Well, I think we're all wisest to assume that we could have this virus at any time, and we could catch this virus at any time until we have good evidence from the literature to prove that otherwise. And that means following the precautions that we are trying widely to distribute. Put your mask on, have everybody put masks on, keep social distancing. Those things really matter. And I would make the assumption that it's possible to get something back, even if you've had it. So just go ahead and take the precautions. I still think it's likely that we're generating protective response for most people. That with a history of respiratory viruses would suggest that's the most likely scenario. But given how recent this has come up and how much we don't know, it's always wiser to be erring on the side of caution.
The more unknowns, the more caution that's called for,
Right,
it sounds
exactly.
like. We have a question from Tina at Science News. Tina, I want to make your audio live and give you the chance to ask this if you'd like. Tina, go ahead.
Yeah, so Dr. Ostrosky, you mentioned that antibody responses seem to be waning over a few months or so. Is that necessarily a bad thing? I mean, isn't that something that happens normally when you catch a cold or something? And do you need the antibodies to stay high in your blood to get protection, or do you just need memory B cells that can then crank up antibody production if you encounter the virus again?
That's a great question, Tina. And the theme today is we just don't know. The reports that are sort of bringing forward the winning antibody titers are coming mainly from China at this point, where they've experienced the infection before all of us. And they're noting a decline in antibody titers that's about 4 months out. But like you say, there's other possibilities. There's a possibility to reactivate those B cells. There's the T cells that are going to be working there. We just don't know. This is a virus that's brand new to all of us. All of us have known this virus for about 8 months now. That's the most we've known about it. So a lot to learn.
We have a question from Emiliano Mega from Salud con Lupa about asymptomatic cases. This is the next topic that I want to get into. Emiliano, would you like to ask your question?
Yeah, thank you so much. So I think I have two questions, actually. I was wondering whether asymptomatic people also develop kind of lung damage and also the this overactive immune response that we see in patients with symptoms. What do we know about that so far? Also, my next question is, and I'm sure this may not have an answer, do we know what makes certain people more likely to get the virus and not develop symptoms?
Thank you, Emiliano. Dr. Dutch, would you like to take
Sure.
that first?
Let me start with those. First of all, in terms of the first one, can asymptomatic people actually be having some kind of damage go on? There are some reports that suggest that can be the case, that sometimes people will not feel that they were ill, but that if you actually went in and did careful analysis of their respiratory tract, et cetera, you can see some damage that would be consistent with a viral infection going on. So some asymptomatic people may simply not be perceiving those changes are going on and not be getting ill enough that they notice it. So you can't rule out the possibility that someone might have some longer term issues that they're dealing with because they had the virus but weren't aware of it. In terms of things more likely to make us asymptomatic or ill, the small amount of stuff I've seen on this would suggest, for instance, age is one of those. There was a report out of South Korea that suggested that younger people, just as they're less likely to get really ill, they're also less likely to feel ill enough to think they have anything. So they're more likely to be asymptomatic. Older people are much more likely to have symptoms when they catch this virus. So that would be one of the things that we would be looking at. I believe those were the two questions. Did I miss something else?
I think that was everything from Emiliano about this. And we talked a little bit about the asymptomatic and pre-symptomatic cases being a major topic that we wanted to tackle today. So I'd like to follow up with you about that, Dr. Dutch. And what we've seen is a lot of data and recommendations changing regarding the threat of asymptomatic people spreading the virus. What's our current best understanding about that for whether or not that's true, or also when the virus is most infectious? And I think we'd go from there.
Okay, so, and I realize this has been an area of some confusion. Last month, there was a report that seemed to come from the World Health Organization saying there wasn't an issue with asymptomatic spread. They retracted that the next day because scientifically that doesn't seem to be accurate, and it may have just been a misinterpretation. The evidence suggests that people who are asymptomatic, for the small number of studies where you've been able to follow them, are replicating virus in their airways and have infectious particles that could spread. So far, all the evidence suggests that people with asymptomatic infections are capable of spreading the virus. If you look at, for any person, when we're most infectious, it fits with what we see for many other respiratory viruses. And unfortunately, what that means is you're actually most infectious before you even know you're sick, which can make it really difficult. The same thing is true with flu. The day or so before you know you have symptoms, you're already very contagious. With this virus, it looks like the few days before symptoms show up is when you're peaking the amount of virus in your upper respiratory tract. And that's what you would cough out or breathe out. So that would be your infectious particles. So it would seem like asymptomatic and pre-symptomatic, which is people who will go on to generate symptoms, are likely both sources of transmission.
I want to dig into this topic just a tiny bit further, and then I'm going to call on one of our freelance media in the audience for her questions. But I want to ask a little bit more about this. And to Dr. Ostrosky, that period of time, that number of days, pre-symptomatic, or obviously if they never develop symptoms, asymptomatic, is that atypical in coronaviruses or other respiratory viruses? Or is that period of time much longer than other kinds of infectious disease that we've dealt with before?
That's a very good question, and it's exactly as Dr. Dutch described it. The period where we're probably most contagious is the 48 hours leading to when you become symptomatic. So if we looked at a curve, you would peak sometime around the time you actually become symptomatic. But those 48 hours before, you're already shedding active virus. And then your curve starts going down dramatically up to the point where at day 8 or so, you're really not shedding enough virus to be infectious. And if you detect RNA, it actually has translated into not being to even culture the virus in cell culture. So this is fairly typical of respiratory viruses, nothing strange or abnormal going on here. It's just very difficult when you are testing somebody who doesn't have symptoms to know if they're in the up side of the curve or if they're already coming down. And that makes a difference to classify them as infectious or not.
So correct me if I'm wrong, that's at least twice as long, if not longer, than the infectious pre-symptomatic period for influenza, right?
It's about the same. It's about 48 hours as well.
It is about the same. Okay. That's helpful to understand. I think that there's been certainly a lot of confusion about when people are contagious and the risk of spread before someone even knows they're sick being a major cause for concern. I want to call on Charlotte Lieboff. Go ahead with your question, Charlotte. I'll make your audio live. Go ahead.
Okay, thanks, Tom. My question is a little off topic, but I want to take advantage of having these experts here. So I'm coming into you from Florida, so we're obviously very concerned. And what I wrestle with constantly is trying to convey to people how deep the concern is, what we really do have to be worried about. And last night I noticed one of the trackers I followed had started a new category for Florida and the other 24 states where the disease is spreading a lot. Previously, they had colors that denoted trending better, caution warranted, and trending poorly. And I see they have just added uncontrolled spread. And I didn't want to just throw that up there without telling people what it means. So could you tell me, because when they hear pandemic, they already know it's spreading. How do I convey this extra level of caution to them?
Dr. Dutch, would you like to take that?
I can try. Obviously, I don't know exactly their definition of uncontrolled spread. What happens is you get more and more cases within your community. And because each case can transmit to several other people, the average is thought to be with each person transmits to 2 to 3. That's an average, but we have some super spreader events that can go even more. As soon as you get enough of your population infected, the chances that you'll run into it when you're out go up and up and up. And I would consider that is what you're meaning with uncontrolled spread. It's not sporadic that you run into someone. It's actually much more likely. I would add though, because so I'm a virologist by training, I study emerging respiratory viruses and the molecular details of infection. So I should check with Dr. Ostrosky to make sure that that's how he would define uncontrolled spread.
It's very
Dr.
interesting.
Ostrosky, go ahead.
I would love to see that metric. The way I would interpret that is when you have spread that exceeds the public health capacity to track and isolate and do contact tracing.
Right.
That would be my definition of uncontrolled spread, when we've exceeded all normal ways to track and control the disease.
And so how do I convey to people that this has just upped your danger of being infected more than it was?
That's a wonderful question. So I'm sitting 1 month from opening the University of Kentucky to 30,000 undergrads and trying to figure out how to make sure they take this seriously. I think one is this issue of relating it to how frequently they're likely to be running into an infected person. I think that many people have thought this was rare, that there's no chance I'll run into it. But realistically, if you were living in some of these states, and particularly some of the communities, you're going to run into this a lot. I know in New York, just last week, there was a report that one of the areas of New York, which I think is actually called Corona, it's a borough of New York, something like 68% of their population tests positive for the antibody now. So that tells you that moved into that community and it spread incredibly widely. And if you were in places like Florida, I have a son in Texas and a son in LA, it's spreading there. And when you go to Kroger, when you go to everywhere, you almost for sure are running into people who have this when you have high rates of spread going on. That'd be the first thing. The second thing is to make them look really seriously at the hospitalization rates and the status of your intensive care. I always say to my kids who are in their 20s and are healthy, you'll probably be fine. You might actually have some lung issues for a while. Some people do, but you'll probably be fine. But if your ICU is swamped and you get in a car wreck, you might not be fine. If your ICU is wrecked and the neighbor that you accidentally got this virus to needs treatment, they might not be fine. So we need to start thinking about each of us taking responsibility for protecting not just ourselves, but our communities. And that's a hard message to get across, but I think it's an important one.
Thank you for your question, Charlotte. We'll come back to you for another one. I want to let another question come up first, though, because it relates to something that was mentioned in Dr. Dutch's answer. Benita, you had a question about antibodies. Please go ahead.
Yes, I do. Given that the antibodies may drop off, but the B and the T cells would have memory, is there any way to measure that, especially in someone who may have been infected, that they had a mild symptoms, they didn't get a positive test? So is there any way to determine if that person may have some ongoing protection?
So the rough answer is yes, but it's not yes like you could go to Walgreens and do this. So the antibody tests that have been developed are getting more widely distributed. T cell assays can be done. That they're in the reports that go out. We have a lab here at the University of Kentucky that can do T cell assays on patients, but they're much more specialized and they're not developed in any kind of kit or assay that a clinical lab is doing right now, as far as I know. So in terms of studying this, yes. In terms of on an individual basis going to get that answer somewhere quickly, not as far as I know.
Dr. Ostrosky, anything you'd like to add to that?
Yes, again, this unfortunately is a lot more labor intensive. It requires kind of a research lab setting, and it's going to take many months before this is commercially available, if it turns out to be useful at all.
Thank you for your question, Benita, from the newsroom there at WNYT NBC in Albany. Thank you. Charlotte, you have another question I believe you'd like to ask. Go ahead.
Yeah, again, a little off topic. And I think there's been a lot of concern about the numbers that Florida is reporting. And one thing that is confusing is the issue of diagnostic tests, antigen tests, and antibody tests. And I was just sort of trying to take a quick look. I didn't get a chance, but I think the issue was that Florida had started combining diagnostic and antigen testing. And that's not necessarily a good idea. Can you tell me about that? And then also explain if there's a difference between antigen and antibody testing, or if those are, you know, interchangeable.
Dr.
Sure,
Dutch, please
I
feel
can start, yeah. So the let me just briefly tell you what the three tests are. So the diagnostic test you're describing is actually looking for the RNA in the virus. So these viruses have an RNA genome. We have something called DNA that carries our genetic material. Coronaviruses never use DNA, they use RNA. And so that test is looking specifically for whether RNA from the virus is present in the person. And usually with a nasal swab, sometimes down the throat. The antigen test, so antigens are parts of the virus that your antibodies are interacting with. So the spike protein on the surface is a very common antigen that is going to be bound by those antibodies. So those are tests that look for essentially primarily viral proteins. So combining, if you had the same patient, they likely would be positive on a diagnostic and an antigen test because both look to see, is there a virus present in your body? You might have patients stay longer diagnostic because they have viral RNA, but not a lot of particles. But combining them might well double count. This other one you're discussing is antibodies. That looks to see whether a patient's system has generated antibodies that recognize the virus. So that's a test to see, have you been infected and mounted an immune response? So that's a very different type of test. And you'll stay antibody positive generally, hopefully for a long time. We're still figuring it out, but at least longer than for most people than you would stay RNA or antigen positive.
Dr. Ostrosky, is there anything you'd add to Charlotte's question about the testing?
Yeah, so combining molecular, antigen, and antibody testing is problematic because you're basically adding into the basket active infection with evidence of previous infection, and you may have overlapping patients in that same bucket. So unless it's very, very well done, excluding duplicates and looking at timelines of things, it is problematic, and it may not be able to allow us to compare apples to apples between states and counties, even within a state.
Dr. Ostrosky, with questions about the asymptomatic cases and pre-symptomatic phase, how does that connect up to our best recommendations for testing and when someone should get tested in order to make sure that their results are the most accurate as possible?
So the one thing everybody agrees on is if you have symptoms, you need to be tested. And again, we ask people to have a very low threshold as to what we consider coronavirus symptoms, because we have anything from headache to diarrhea to a sore throat to full-fledged fever and shortness of breath. So in this day and age, if you're having anything that's remotely abnormal from your baseline, any new cough, any worsening cough, any different nasal congestion that you normally have, I would recommend you get tested for coronavirus because it could be an actual infection. Where people disagree is really what to do after somebody's exposed to coronavirus. And the reason we disagree is because once you're exposed, you actually have the whole 14-day incubation period to become positive. And yes, most likely you're going to be becoming positive within 4 to 7 days, which is kind of the 95% confidence interval for the majority of people. But there's some people that are going to be doing that earlier and some people that are going to be doing that later. And so the sort of the knee-jerk reaction once you hear you've been exposed is, I'm going to go ahead and get tested. And you actually may be testing too early to detect the virus and creating a false sense of security that you're okay when you still need to be sort of quarantining for the 14 days. So we generally recommend people to get tested when symptomatic. And after an exposure, if it's important to you to be able to sort of go back to work or go back to school, we want you to wait at least 5 days from the day of the exposure to be tested.
Great, thank you, Dr. Ostrosky. We have a question from someone in our audience, not a reporter, but a health provider and someone who's on a school opening task force. Her name's Ella. Thank you for your question in the chat, Ella. Are asymptomatic children potentially disease conferring? I don't know whether or not we know this, but Dr. Dutch, do you have any thoughts about that?
So the few papers I've read, and again, this is an area of ongoing research, suggests that children who have an infection are generating infectious particles. So that they are able, I mean, and it would make sense if they're infected, they have viral particles in the airway. Given that, it would seem most likely they could be infectious. I don't believe I've seen a study that actually looked at transmission between children. So the answer is most likely yes. The only thing that's interesting is there were a few reports that I read out of Europe in particular that didn't see a huge change in spread rates with or without school closings, which would suggest that maybe children are not the massive incubators of virus transmission for this that they may be for some others. For instance, we know with influenza, children are our major source of the spread of this virus. They just spread it like wildfire and take it home. It's not as clear that's the case for the coronaviruses. But again, we're really in the infancy in figuring that out.
Still a big unknown. Dr. Ostrosky, would you add anything to that?
Yeah, I think the way we approach children currently is we think they're no more or less likely to be infectious than an adult. They can get as easily infected as an adult. They're not going to be spreading it more than an adult either. And what we do know in children is that they seem to fortunately get sort of milder forms of the disease, although there are some very severe forms in children. So this is all playing into this very difficult equations as to when to bring back kids to school.
Something that occurs to me, Dr. Ostrosky, is if younger children are carrying the virus but they're asymptomatic, they're therefore less likely to cough and sneeze. Is that potentially a factor in reducing at least that they might be transmitting it?
Again, it's no more or less likely than an adult acting the same way. So I don't think we need to carve out children as special populations.
And children like to yell.
Yeah.
So that probably offsets some of the not coughing and sneezing.
Yeah, absolutely. We have another question from Tina at Science News. Tina, go ahead.
So this question is sort of about the justification for wearing masks. So the WHO still doesn't recommend universal mask wearing, and they've been reluctant to say that the coronavirus is airborne. But the possibility of aerosol transmission is cited as one of the reasons for wearing masks. So what's the evidence for and against aerosol transmission? And is that the important factor for why people should wear masks, or is it the asymptomatic or pre-symptomatic transmission possibility, or is it a combination of both?
Dr. Ostrosky, do you have thoughts about that?
I have a lot of thoughts about that. Unquestionably, masks are a game changer. I mean, we've seen it in our hospital. Before we started universal masking, we had a lot of transmission between staff, between patients and staff, etc. The moment we implemented universal masking, that all went away. It was very, very clear. We went to a pattern where now most of the transmission we see in the hospital is between staff members that take off the mask to eat together. So, and then there's a lot of research out there looking at masking in the community settings, showing a significant decrease in transmission. There's a lot of now really good case reports for, masking, for example, the one that came out in the MNWR today, this salon where two stylists were sick with COVID. They were wearing masks and none of the clients got the disease. So in my opinion, there's really no controversy as to whether masks help decrease the transmission of this virus. And it's only a matter of time before WHO catches up to this. I don't know if you want to say something about that, Dr. Dutch, before we address airborne or aerosol.
I completely agree. The data is very strong that masks matter. There was an epidemiology paper published about a month ago that really went back and looked at Italy and New York and looked at what their transmission, what the curves were, and then put in the time point of when was mandatory mask wearing put in place. And you can see a shift in the curve in both places of like 4 or 5 days after that date, which would fit with the idea that when we all start to put masks on, we decrease transmission. Are we decreasing it to 100%? No. But what I always say to people who are not so fond of this, oh, it's not perfect, oh, we don't know, is, you know, if you were about to go in a room and people were going to shoot at you and you had the option to put something on that some data suggests is going to protect you 90% of the time, would you do it? And the answer would be yes. Same thing as if you were for your loved one, would you have them do it? Yes. So this is, again, a choice that has good scientific evidence to suggest it will really make a difference. And no scientific evidence to suggest it's causing problems. I don't particularly like wearing a mask, but I'm not a huge fan of seatbelts, but I wear them every single time I get in a car. They're not comfortable, but I wear them. And it's the same kind of thing.
Dr. Ostrosky, did you want to also comment on the question of airborne transmission?
Perfect. So we're in the midst of a huge academic debate of airborne versus droplet. So just to set the point here, what we think of airborne in infection control and epidemiology are things that are suspended in the air and can travel long distances. So, for example, if you had an auditorium where there's somebody with measles or chickenpox or TB, the particles would disperse all over the auditorium and you would have almost anybody who's susceptible be infected. That's what we call airborne in infection control. Then there's droplets. Droplets are bigger particles that usually are pulled down by gravity. They have a trajectory and they can travel at the most 1 meter or 3 feet. So the current thinking is that this virus is primarily transmitted by droplets. They have large amounts of viral particles, and perhaps there's an inoculum that's needed to infect somebody. And then we have a new generation of engineers and scientists that sort of started to do experiments, and they found that they could aerosolize virus, and you can detect RNA in these aerosols. And the conclusion is that, oh my God, we have an airborne thing here. And when we actually don't know if these aerosols, again, can produce infected particles. We can detect RNA for sure, but we don't know if we can grow virus from these aerosols. And these aerosols aren't really going to be floating around in the air. They can linger around, but they're not really sort of expanding and being viable like we would see with other diseases. So the debate right now is if this virus is airborne or aerosol mediated, and the answer to that is probably somewhere in between. The primary route is going to still be droplets, but we do know that you can have some aerosols that may linger around the patient for a patient that's positive, and they may linger a little longer than you would in a very close space with poor ventilation. So that's the current thinking. There's a letter that got written to the WHO and CDC by a group of scientists requesting that CDC and WHO acknowledge this is airborne. And WHO responded with, we read your letter and we think there may be a role for aerosols, but the reality is we don't think this is airborne in the sense of what we call airborne things in epidemiology.
So is it correct to say then, Dr. Ostrosky, that the virus must be suspended in some form of liquid when it comes out of an infected person's mouth? It can't just, the virus can't just by itself survive in the air.
So I'm going to let Dr. Dutch answer
Okay.
that. This is a virologist.
Oh yeah. So again, I wish I could give you an absolutely firm idea, but what we think is that most viruses that are coming out like this are more stable if they're on these droplets. So coronaviruses are these tiny things, and they have a lipid membrane around them. Kind of think like a what you think of with an oil coating the genome. That's not all that stable out there. But if you have a number of them put together, and they're put together with some of our respiratory secretions, it provides a more stability as they move out. And that's true for most viruses. Many viruses, particularly respirators, aren't that stable when they're outside of cells. So the thinking is that most of them are on these kinds of droplets. Could I promise you that there's not a single case of a viral particle out there? No, there probably is, but where are the majority? So I think that Dr. Ostrosky is completely right with what he was talking about. Most of what we think is going on is these droplets. That's why 6 feet came up as an idea. That's where masking comes up as an idea. Is it possible that there's some aerosolized virus? Yes. As you probably hear from both of us, none of these things are simple to say this is exactly all the cases and this never happens. What we're saying is this is probably most of the time, and occasionally you have some of this. What we don't have, though, are any reports that I've seen of virus, for instance, spreading through air conditioning systems in apartment buildings, or spreading to the office 4 doors down, even though you didn't see the person. The examples that are brought forward to suggest airborne are all things like a restaurant where the tables were further than 6 feet, but people were sitting in there for a long time. And at one part of that restaurant, more people got sick. Things like that. I think it is worth looking more carefully at ventilation. I know when we're looking at how we properly deal with lectures this time, I certainly think looking at it to make sure you're well ventilated is a good idea. It's also why being outdoors is likely much safer. You don't have some of the issues you might have indoors. But I think we still have to stick with, as much as possible, stopping all the short-term spread that we know is going on, and then starting to look at, is there a small percentage that's this longer-term aerosolation? And if so, how do we reduce it?
We have a question from Helene Bednar. She's a freelancer. She's asking about a report that came out today citing the presence of a rash in the mouth or potentially on the skin as an indicator of infection. I wonder if Dr. Dutch or Dr. Ostrosky, you know anything about that?
Well, we certainly get a lot of interesting symptoms with this virus. It's not impossible that this could be that. I haven't seen the report yet. Certainly within the nasal cavity and mouth, we get some things that are more unusual for this than some. One is a loss of taste and smell. As someone I know who recently had this experience, that complete loss of the ability to taste or smell for 10 days. So you're certainly getting active replication up in the nasal epithelium, up through the areas of the mouth that could generate some kind of a rash. I haven't heard of this, though, as a common symptom.
Dr. Ostrosky, any knowledge about reports of oral rash?
No, we're still finding more and more reports of atypical manifestations of COVID, like this, like skin nodules. And the reality is that this virus is going to become so prevalent that you're going to start seeing this virus with other things, right? With other illnesses. And that's where it gets really tricky epidemiologically to see if this is a finding of COVID or with COVID. So looking forward to seeing more data on this. But in any case, it would be an atypical and a rare symptom that we see.
Another question from Tina at Science News. Tina, go ahead.
Hi, I was wondering, is there any good data to tell us what actually an infectious dose of the coronavirus is at this point?
No. For most viruses, it's quite a bit more than 1. But as you can anticipate, that's a really difficult experiment to do. First of all, I assume what we really want is an infectious dose in a human. We can't do those experiments. So I'm sure we're looking with animal models. There is several good animal models that have now been developed to try to start determining that, but I haven't seen a published paper that really carefully looked at that.
Dr. Ostrosky, any thoughts on that question?
Yeah, again, we're barely having any quantitative assays for this virus at this point. So first we need to develop the technology for quantitative exposures. And as Dr. Dutch said, it would be unethical to sort of purposely infect people. But then, and, you know, I see experimental designs where you can walk around a hospital and see what the doses are and look at how many people got infected in an area or another, et cetera. So more to come on that. But I do believe there could be an inoculum effect here. Going back to Emiliano's question about who's going to get sicker, you know, we think there's probably genetic determinants as to your immune response to the virus that are probably going to explain why some people don't get anything and some people end up in the ICU with wide lungs. And another explanation could be really the dose, the infective dose or the inoculum. And I do feel that anecdotally, you know, people that have very large exposures are more likely to get the disease.
That's a great question, and it seems like we've had a couple of other questions in the chat get answered in the course of answering that question, both from Kids Community Dental Clinic, one of our attendees, asking similarly, the more virus you're exposed to, does it mean the worse the disease effects are? Do we know anything about maybe prolonged exposure in a small space, say within the same household? Does that potentially result in, you know, the next person infected getting a more severe case, or is it still just so variable from patient to patient that that can't be traced with good control?
It's really fascinating to study the cases we're seeing, because I've had families where one member has it and the whole family gets it, you know, 6, 7 members get it. They're all in the ICU, super sick, and that happens. And then I've had cases where, you know, I have a patient that has the illness and he doesn't isolate himself from his wife. They're still sleeping in the same bed, sharing meals, etc. And the wife never gets it. And we know she never gets it because they're both like physicians and they're both getting tested repeatedly, and one of them never gets it. So it's we still need to learn a lot more about this virus.
From the chat, on the topic of the earlier question about oral rash, a very helpful comment from Raquel. She chatted a link to an article comparing the lesion to similar to herpes simplex virus, and that is in the chat if anyone is interested in exploring that particular idiosyncratic symptom further. Also, Benita from WNYT in Albany asked further about the person-to-person variance in the load of virus or the severity of disease. I would love to mention one study that I'm familiar with that is coming out in about a week from one of our members, the Sparrow Health Research Organization based at Temple University in Philadelphia, Dr. Antonio Giordano there. They have studied the HLA gene and taken data from Italy, now that it's been, you know, significant time since their peak of the disease, and they studied variances in the different alleles of the HLA gene system and may have identified particular ones that may indicate worse or less bad spread. That should hopefully be coming out in the next week or so. If anyone is interested in that, you can contact me and I'll connect you with them about that. I just happen to be consulting with them about their release about that. Dr. Dutch, I'd like to ask you kind of about these asymptomatic patients potentially still having actual symptoms that they might not be aware of. Is this something that can be seen on a chest scan, for example, like changes to the lungs that they might not really realize have happened?
I will tell you right now, this is primarily anecdotal from things that I've heard from some MDs. So I'd also love Dr. Ostrosky to comment on this. But I've certainly heard a few reports from people that they have someone who didn't really realize they had it. They come in, they're antibody positive, and they actually have it. They have lung symptoms that look like they've been infected. Or patients showing up to ER who don't really think they're sick, but they actually have lower pulse ox readings, and they shouldn't have felt fine, but they seem to. So those are all kind of worrisome symptoms, meaning people are actually ill. They just somehow it's crept up on them and they haven't identified it as being a real problem.
Dr. Ostrosky, any thoughts about that or further comments there?
Yeah. So we have very interesting patterns as well. Again, the situation where somebody's walking around, they feel fine, and you put in a pulse oximeter on them and they're setting, less than 90 and they're feeling fine. That's what we call silent hypoxemia. And it's something that we're looking at as a common presentation, particularly in younger people that can tolerate hypoxemia better. And then the other thing is we've noticed it in our trauma service. We have people that have big car accidents, they have strokes, brain bleeds, etc. And then in the workup, they get a CAT scan of the chest, and wow, we found the classic signs of COVID there. So it's really interesting to know that there could be such level of affection without clear signs and symptoms before the presentations.
I'd like to go to Charlotte for a question about blood types.
Right. Thank you. Yeah, there seemed to be a pretty much agreement.
Oh, so sorry, Charlotte. I didn't mean to mute you. Go ahead again.
Yeah, there seemed to be a pretty much of an agreement on early reports that blood type mattered, that people with type A were more likely to get infected. And then in the last day or so, I think there was a pair of studies that came down saying that this really isn't possibly the case. I know all early research is early research, but do you have any views on this?
You're exactly right. The research is research. And I try to always stress to my students, and including the ones I teach, that scientists keep learning, and that's why the story changes. When I teach virology, it's different every year because we learn new stuff. So there are several reports that suggest that this linkage is there. There were early reports out of China that suggested that patients with type A blood were more highly represented in the patient population than you would expect, and those with type O were underrepresented. The other report that suggested this would also be important, there was what's called a GWAS study, genome-wide association study, that came out of Italy relatively recently, and they found 2 areas of the genome that seemed to link with increased infection rates. And one was the area around where the blood type genes were. There are, however, some other genes in that region, and it remains possible that it's not actually the A thing, it's something related in the genome that was having an effect. Now, I haven't seen the reports you talked about today. In all of those studies, it wasn't an all or nothing. It's not something where I would say, I'm type A, my cousin's type O, you have to go to the grocery store because you're safe and I can't go because I'm in danger. It just elevates your risk. Just like being slightly older elevates risk, other things elevate risk. So I think it's one that we'll have to keep teasing out the story.
Dr. Ostrosky, anything you'd add to that?
No. This started as an epidemiological observation in China, and then the Italian study really brought us the granularity as to what genes are involved, and they do show, in my opinion, a clear association of severe forms with type A and a protection for type O. It's not really the blood type, it's sort of where the genes are, as Dr. Dutch was explaining, and the concentration of these genes in those blood types. But I think more to come on this story.
I'd like to ask about one other recent news development, and then we'll kind of work toward a close. I know, Dr. Ostrosky, you have a hard out in about 5 minutes, so I want to make sure to get you where you need to go. Reports in the last few days about changes to hospitals and where they're reporting case info, switching that to go to a more centralized database at the Department of Health and Human Services in Washington rather than directly to the Centers for Disease Control. Dr. Ostrosky, is this a sign of concern at all, or what are the pros and cons of making a change to the reporting mechanisms here for the hospitals?
So I'm gonna start off by saying that I'm maybe naive, but I see this in the field. the way we started to report COVID data to the government was through an existing system called the NHSN that we use for reporting healthcare-associated infections. So there was no system to report COVID to Health and Human Services or CDC. They sort of created a new module for NHSN, and that's how we've been reporting COVID. But it was kind of what I always say, it's kind of a Jimmy rig system. It wasn't designed to do that. And now they rolled out a specific system to directly report the cases to HHS. Of course, people are weary about this. There's a lot of mistrust. I see it really as a more direct route of the data to where it needs to go for big decision making. And nobody's saying that CDC is going to be excluded from seeing this data or from looking at it. So I'm maybe a lone voice here, but I'm not too concerned about this.
I think that's very reasonable and somewhat reassuring, Dr. Ostrosky, but certainly a lot of people may be skeptical or suspicious with the regular contradictory or inconsistent messaging from some public officials. And so, Dr. Dutch, I want to ask you if there was any evidence of data being suppressed or anything like that, how would we know, and what would reassure people about this?
So I think to answer the first question, my concern, what we want is transparent and available data. And as long as this new reporting system generates that, then this is great. And there have been complications from what I can tell, and I'm Dr. Ostrosky would know much more than me with the CDC system. It has not seemed to work incredibly well some of the time. What will matter is whether now data flowing in is readily accessible to the CDC, to other units who are looking for this data. That's how we'll know if we have problems with people who are doing modeling, accessing the data they need to do the modeling, then we'll know that you're not getting access. If we're instead getting, those people are readily able to access the data, be given the data, and the data is complete and appears to be hopefully an improvement on what we've had, then we know that the system was working. And I think we're going to have to look and see.
Thank you, Dr. Dutch. With that, we'll get drawn to a close. I want to do a quick plug. We're gonna have another one of these next week, possibly actually 2 of these next week. So please stay tuned for information about those. One will be focusing on cases of COVID among cancer patients. And we're also convening a panel to talk about the debate and controversies about mask ordinances and what are the objections, what's the science about that. So we had some questions earlier about the effectiveness of masks. I'd encourage you to join us next week to discuss that further. With that, I will say thank you to Dr. Dutch and to Dr. Ostrosky. For any media who are on the call, we will make sure to get you the video and the transcript. If you're not on the registration list, send us an email to info@newswise.com and we'll be certain to get you that information once available. With that, I will say stay safe, stay healthy, and good luck. Thank you very much, everyone.